The importance and use of defibrillation in pediatric surgery. Nida. Introduction. Pediatric surgery involves the diagnosis and treatment of congenital or acquired conditions requiring surgical intervention. The role of defibrillation in addressing cardiac arrest incidents in children during surgical procedures underscores the essentiality of defibrillator utilization in surgical setting. Cardiac complications pose significant risks during pediatric surgeries, cardiac impacting both patients and the surgical team throughout and after procedures. Understanding and effectively managing cardiac issues in pediatric patients are paramount in ensuring successful surgical outcomes and overall patients' well-being. Common cardiac complications in pediatric surgery. Pediatric surgical procedures carry inherent risks due to the distinct anatomical and physiological characteristics of children, with cardiac complications being a primary concern. Anesthesia-related cardiac issues, surgical stress-induced complications, blood loss-related hemodynamic imbalances, and instances of cardiac arrest present critical challenges that can affect the general health and treatment outcomes of pediatric patients. 1. Anesthesia-related cardiac complications. Anesthesia plays a vital role in ensuring safe and painless surgical procedures for children, but may lead to certain cardiac issues. Bradycardia, hypotension, and arrhythmia are common concerns during pediatric surgeries, with precise monitoring and management being essential to prevent adverse effects on the heart and overall health. Bradycardia. It is the abnormal slowing of the heart rate. Children are more sensitive to anesthesia and have an increased risk of bradycardia. The limit values of bradycardia are determined according to age 6. 1. Newborns 0 to 1 month less than 100 beats/minute. 2. Infants 1 month 1 year less than 90 beats/minute. 3. Young children 1 to 3 years less than 80 beats/minute. 4. Preschool children 3 to 6 years less than 70 beats/minute. 5. School children 6 to 12 years less than 60 beats/minute. 6. Adolescents 12 to 18 years 50 to 60 beats/minute. Hypotension. Low blood pressure may cause cardiac complications during anesthesia. In children, hypotension may cause inadequate blood flow during surgery. Arrhythmia. Arrhythmia is defined as irregular heart rhythm, and it is a common complication during pediatric surgery. It can occur as a result of anesthesia or surgical stress, and can lead to serious health problems. Accurate and rapid diagnosis and management of arrhythmia is vital in children. 2. Surgical stress and cardiac complications. Surgical procedures cause significant stress on the body, and this may lead to cardiac complications. Myocardial ischemia. It is the inability to provide adequate blood flow to the heart muscle. Surgical stress may increase the risk of ischemia by increasing the oxygen demand to the heart. Heart failure. It is a condition in which the heart cannot pump effectively enough during or after surgery. It is especially likely to occur after long and complex surgical procedures. 3. Blood loss and hemodynamic imbalances. Blood loss during surgery may cause hemodynamic imbalances and cardiac complications in children. Hypovolemic shock. It is a condition that occurs as a result of excessive blood loss. This condition causes the heart not to pump enough blood and the organs not to receive enough oxygen. Transfusion reactions. Reactions that may occur during blood transfusions may lead to cardiac complications. Children may be more sensitive to transfusion reactions. 4. Cardiac arrest. Cardiac arrest is a condition in which the heart suddenly stops pumping blood. This condition causes the flow of oxygenated blood to vital organs to stop and requires urgent medical attention. Cardiac arrest can occur suddenly and can often be fatal within a few minutes. Symptoms of cardiac arrest include sudden loss of consciousness, respiratory arrest, and acrotism. Studies conducted have shown that cardiac arrest during pediatric surgery is more common in children under than 1 year of age, in children who undergo emergency surgery, and in children who have American Society of Anesthesiologists classification of 3 and above. Rapid and effective intervention is required in this situation. Otherwise, life-threatening consequences may occur. In pediatric surgery, cardiac complications are an important risk factor both after surgery and during postoperative period. Complications may affect the success of surgical interventions and the general health of patients. identification and management of these complications require the surgical team to be prepared and appropriate intervention strategies to be implemented. Resuscitation is required for the management of cardiac arrest, which occurs during cardiac complications. Defibrillator use during surgery. Sudden cardiac events that may occur under anesthesia during pediatric surgery necessitate the availability of defibrillators. Research shows that when performed early and correctly, defibrillation increases survival rates in pediatric cardiac arrest cases significantly. In one study, it was found that defibrillation performed at appropriate energy levels produced successful results and decreased complication risks in pediatric patients. For this reason, timely administration of defibrillation requires the surgical team to be trained and prepared. Defibrillation involves the administration of electric shock to normalize the heart rhythm. It should be performed in case of cardiac arrest. Cardiac arrest occurs when the child is unconscious, has no pulse, and stops breathing. The 4 fatal rhythms that may occur during cardiac arrest are ventricular fibrillation, VF, pulseless ventricular tachycardia, NVT, pulseless electrical activity, and asystole. In cases of VF and NVT, shock with defibrillator is required. Ventricular fibrillation, VF. VF is a condition in which the ventricles of the heart make irregular and rapid contractions. In this arrhythmia, the heart cannot pump blood effectively and rapid defibrillation is required. VF is one of the most common causes of cardiac arrest and may be fatal if not treated urgently. Pulseless ventricular tachycardia, NVT. NVT is a condition in which chambers of the heart contract rapidly but cannot pump blood effectively. Defibrillation is required in this condition when no pulse can be taken. Asystole. It is a condition in which the electrical activity of the heart stops completely and ECG, electrocardiogram, appearance known as flatline appears. Asystole is one of the most fatal forms of cardiac arrest and defibrillation is not effective. Treatment occurs through cardiopulmonary resuscitation, CPR, and adrenaline. Pulseless electrical activity, PA/NEA. NEA is the absence of an effective contraction and therefore pulse, despite the persistence of electrical activity of the heart. NEA can occur due to a variety of underlying causes and treatment involves identification and correction of the underlying causes. CPR and epinephrine administration are required. Defibrillator use and administration protocols. Defibrillation is performed in accordance with the protocols specified in the guidelines of authorities such as American Heart Association, AHA, and European Resuscitation Council, ERC. In pediatric patients, defibrillation can be performed with an automatic external defibrillator, OED, or manual defibrillator. Defibrillator is used by healthcare professionals. Healthcare professionals should determine the energy level in shockable rhythms depending on the age and weight of the child. The effectiveness and safety of defibrillation varies depending on the age and weight of the child. Defibrillation can be administered to all age groups except newborns, 0 to 28 days. However, defibrillation methods and device selection vary depending on age and weight. Infants and young children, 1 month, 8 years OED or manual defibrillators may be used in this age group. The use of spoons/pads in settings is recommended while using defibrillators. Manual defibrillators have pediatric spoons placed inside adult spoons. Pediatric spoons/pads provide safe defibrillation by reducing the shock energy. Older children and adolescents, 8 years and older adult OEDs and manual defibrillators can be used in children aged 8 years and older. Adult spoons/pads in settings are suitable for defibrillation in this age group. During the administration of defibrillator, the placement of spoons/pads should be adjusted as sternum apex. There should be a distance of at least 3 centimeters between the spoons or pads. If the spoons/pads are not of the appropriate pediatric size for children under 8 years of age, they should still be used, but the placement should be anteroposterior because when placed as sternum apex, the 3 centimeters distance between them may not be provided and the spoons/pads may overlap. Spoons should contact the body fully. A weight of approximately 3 kg should be applied to the spoons in children under 10 kilograms and approximately 5 kilograms should be applied to the spoons in children over 10 kilograms. Energy level selection should be administered at the recommended doses according to AHA and ERC guidelines during defibrillation. According to AHA 2020 guidelines, while the first shock is administered as 2J/kg, it is recommended to administer the second shock as 4J/kg and the consequent shocks as 4J/kg. It has been stated that a maximum dose of 10J/kg or adult dose should not be exceeded. According to ERC 2021 guideline, it is recommended for the first shock to be administered as 4J/kg, the consequent ones to be administered as 4J/kg, and in case of persistent VF/NVT, 5 shock, the shock dose should be increased gradually. It has been stated that maximum dose of 8J/kg or 360J value should not be exceeded. Defibrillator use skills. 1. Preparation of materials. 2. If there is wetness or moisture on the child's chest, it should be dried. 3. Pediatric size spoons should be removed. 4. Defibrillator should be switched on from the on-off button. 5. Depending on the characteristics of the monitor, there may be some differences in switching to child mode. The defibrillator is switched from off to on while pressing and holding the button labeled child mode. 6. Energy level should be chosen as Joule J, in accordance with the recommendations of AHA/ERC guidelines. 7. The charge button on the defibrillator or also on the spoons is pressed on the defibrillator or on the spoons to charge it. 8. If there are individuals contacting the child, they are sent away. 9. Warnings are made such as defibrillator is being charged. Do not contact the child, do not approach. 10. The spoon/pads should be placed as sternumapex or anteroposterior. 11. If pads are to be used, spoons should be removed and pads should be connected to the defibrillator. 12. After the defibrillator is charged, make sure that everyone, including you, is not touching the pediatric patient. 13. Energy should be discharged by pressing the discharge button on the defibrillator or the spoons. 14. After giving shock, the spoons should be placed on the defibrillator. If a pad has been used, it should remain adhered to the child's breast. Conclusion: the relationship between pediatric surgery and defibrillation is critical, especially in terms of cardiac complications that may occur during and after surgery. Defibrillation is an important tool for the surgical team to intervene immediately, and correct administration is vital in terms of improving surgical results. As stated in the literature, the effectiveness of defibrillation practices is directly associated with the preparation of equipment and training of the team. Therefore, pediatric surgery teams should be well trained and prepared in this regard.